Hey, good afternoon, everyone. If we could move towards our seats, we will get started here. As people are moving towards their seats, I think this is a great time for me to take a photo. So, thank you all for being here today. All right. So, good afternoon. Welcome to the College of Charleston. I'm Wood Marchant. I'm the director of the Collegiate Recovery Program. I'm also someone who's in long-term recovery. Today, you'll hear from people I've been fortunate enough to work with both locally throughout our state who've helped those who struggle with substance use disorder. You'll also hear from the director of the Office of National Drug Control Policy, Dr. Rahul Gupta. At his request yesterday, 9 of my students and I got to meet with Dr. Gupta. We got to share about our recovery and about our program. And I'm honored to be the director of the first collegiate recovery program in South Carolina. I'm proud of my alma mater for starting a program like this as well. And for a more formal welcome to the College of Charleston, I'm going to introduce Dr. Andrew Shue, our president.
Thank you, Wood. I'm so proud that the College of Charleston and our Collegiate Recovery Program are hosting the Director of the White House Office of National Drug Control Policy, Director Dr. Rahul Gupta. Thank you for being here and welcome to the oldest university in South Carolina and one of the oldest universities in the country, and the flagship liberal arts university in South Carolina. I also want to thank those on the first panel this afternoon, Sarah Goldsby, Dr. Kathleen Brady, Dr. Chanda Fonsell, and Judge Brucey Hendricks, who will be introduced more formally at the conclusion of Dr. Gupta's remarks. We're so glad you are all here with us today, and we look forward to learn more from you. Today's topic is one that needs to be talked about often and in public. Recognition of the crisis in overdoses that impacts every demographic in our community and every region in our country is key to understanding how to reduce these terrible events. And as a university president, I know these terrible events all too well. This recognition also applies to removing the stigma around those with substance use disorder and supporting those in recovery. It takes a committed community of stakeholders working together to turn the corner on this crisis. The College of Charleston is one of those stakeholders. Most notably through the work of the Collegiate Recovery Program, as well as our students and faculty members who study and research addiction and its impacts. You know the often quoted line that says, "It takes a village to raise a child." Well, I think that aphorism needs to be extended far beyond childhood. It takes a village to support a person throughout life's complex journey. No one can do it alone. I don't think any one of us can do it alone. I want to take just a moment to thank and recognize 2 key members of our own village here at the College of Charleston. both of whom are graduates of the college as well, starting with Wood Marchant, director of the college's Collegiate Recovery Program, and Judge Bruce C. Hendricks, who helped turn an idea into reality on our campus. Thank you both for your commitment to your alma mater, to this important, life-changing, and life-affirming work. Our village extends outward, out into the city of Charleston, too. I'm so glad to introduce one of our strongest partners, City of Charleston Mayor John Teklenberg. Our city is fortunate to have such a committed ally of the recovery community in Mayor Teklenberg. Please join me in welcoming Mayor John Teklenberg.
Thank you, Mr. President, and as Mayor Dr. Gupta, official welcome to the City of Charleston. It's a pleasure to have you here, but it's even more exciting the opportunity that we have together to collaborate on this important issue. If I may just veer off for a second, I brought with me a copy of this article that ran in Sunday's paper, maybe not directly related to this topic, that President Hsu wrote a commentary of the case for kindness and civility. And Mr. President, thank you for that, this insight. It makes me, I'm a musician, so I always think of some song, right? The song I thought of when I read this, Mr. President, was accentuate the positive and eliminate the negative. And he really does a fine job on making the case for us to be a more civil and kind and compassionate society in general. And so I'd been thinking about this for a little while, and I just asked him, and he agreed. We're going to start a Charleston kindness campaign, and Mr. President is going to be one of the co-chairs of that effort, so thank you for agreeing to do that. And how does this relate to the issue of addiction? Well, we got to show a little compassion and love to help those overcome addiction, right? Wood, thank you for what you do. And this whole issue of the stigma of addiction, it touches all families that I know. I don't know a family in Charleston that doesn't have some family member that has dealt with an addiction or drug abuse or alcohol abuse problem. So, it's a collaboration. It's a community-wide effort, and you're right. The City of Charleston is here as one of your partners. And Gil, thank you for stepping up and your service of after Judge Hendricks asked you to help form the Addictions Crisis Task Force, ACT, and we're going to act now, right? It's time to act. Y'all have already been acting to collaborate. And y'all, we have a really great opportunity right now in front of us, because we have some funding that's coming together. We have some resources. The City of Charleston applied collaboratively, and we received a $900,000 grant from the Department of Justice to be able to work on these issues together with our whole community. And then just about 2 weeks ago, I don't think it's quite finalized, and the City of Charleston isn't getting as much as some other jurisdictions, but on the opioid settlement, I believe this year we're going to get about $1.4 million, and the county will be getting some. And so I would like to ask that the ACT task force think about how we can collaborate with the funds that are coming in to the various jurisdictions, and let's be smart about how we spend this money over the next few years and really make a dent in helping those who are dealing with addictions. So what a great opportunity we have. I also want to point out it's an issue that we deal with often at the city, and that's helping those who are experiencing homelessness. So I used to think that about 80% of those in the community that are experiencing homelessness have some kind of mental or addiction problem. and on very reliable, hands-on information from our team and my own experience, it's not 80%, y'all. It's 100%. It's 100% of those who are experiencing homelessness have some kind of, over time, developed. Normally it started with an addiction and it's led to some other mental health issue. So let's not forget our outreach to those who are experiencing homelessness. So once again, I'm going to accentuate the positive. I think even though this is a real crisis of sorts in our community and our country, the number of folks over the last year, the increase of folks who've been dying from opioid addiction and other addictions, that we have a real opportunity to collaborate together as a community, as a region, and we have some resources coming along, and thanks to the leadership of Judge Hendricks and Gil and all of you together here today, we're going to make a difference over the next few years, and with the help of Dr. Gupta as well. Congratulations on your position, and once again, welcome to Charleston. Glad to have you here often.
Well, thanks to the president and thanks to the mayor. I love the kindness campaign, and maybe I can assist with that as well. I'd be happy to. I will jump in and help as I can. Anything with that I can help the college and you and the Collegiate Recovery Program, I'm all in. The Collegiate Recovery Program is a key partner in the Addiction Crisis Task Force. It's imperative that we help these college kids get off to a good start in life at the college and not lose their lives, literally, while they're at the college. And so the college is near and dear to me, and I think Wood has been transformational in his work here and leading at the College of Charleston, and as a result, leading throughout the state of South Carolina, because every college and university is afflicted severely with this problem, whether it be a public institution or a private institution. And this is a model that is key so that we can have these young people graduate from these institutions healthy and happy and able to be good, kind citizens of the United States. Wood and I go back many, many years. And I think I stole him from MUSC and brought him over here. And he, with his experience in recovery and his experience in counseling and his experience at the College of Charleston, has been essential to understanding the facts on the ground in the collegiate community and the education community more broadly. The program has been in place since 2016. As was mentioned, it is proudly the first collegiate recovery program in South Carolina. Our dear friend, Director Marchant, hosts daily recovery meetings in the student lounge right here, which is a dedicated space for these students. 21 sober students will have graduated at the end of this spring semester. The collegiate recovery program students have spoken at least 15 local middle and high schools about their addiction and their subsequent recovery. And maybe, this is a dream, but maybe collegiate recovery could be extended to high school recovery programs. And I know parents from around the country, in talking to Director Marchant, have specifically sought out the College of Charleston because it has such a program, because substance use disorder is so prevalent on so many campuses around the country. Parents are literally afraid to send their kids to school, and they're seeking out these kind of programs. And I've met some of these students, and boy, when you put them on a project, they get on it. They hyper-focus, and they become fantastic students, and then they help broaden the scope of the program, and they mentor other people in other programs. It's just been really exciting. So thanks to Wood for his partnership, for hosting this event this afternoon and for his commitment to this most important issue. He's spoken at our drug court at a graduation ceremony, and he is just always willing and able to help people get well. And now I'm very excited to introduce our guest of honor, Dr. Rahul Gupta, Director of the White House Office of National Drug Control Policy, or ONDCP. Dr. Gupta, most importantly, is the first medical doctor to ever lead the ONDCP and has a truly outstanding record of service throughout his life in public health over the better part of some 25 years. I'll let him explain further what he does as director of the ONDCP. So without further ado, Dr. Gupta.
Good afternoon. Well, let me start first. Thank you, Judge Hendricks. You've been such a gracious host during this trip, and we've learned so much from the work that you do. I also want to thank President Hsu and the College of Charleston for inviting us today. We really appreciate it. Director Merchant, I want to thank you. We were able to have some time with some of the students last night. It was, as always is, eye-opening and revealing to have these, candid conversations of the challenges that students deal with, middle school, high school, and then going into college. As the judge mentioned, how difficult it becomes for children, and we call them children because they're having to make that decision which college to go, and how this is not apparent, this is not clear, it's not very obvious that these programs exist, and that's part of the stigma too. I want to thank Mayor Teklenberg for welcoming us to Charleston. Thank you for your service and for a great city and that you have here. So, I'd also like to thank Commissioner Kurlikowski and my dear friend, who, as well as who has mentored me, who has guided me in this position, who was previously in this position, and we value and appreciate both Commissioner Kurlikowski as well as the real hand behind him, Anna. And thanks to the Addiction Crisis Task Force that we've had a great discussion earlier today. We were able to have a conversation and learn about the great progress that's being made right here, and what a model it forms. I've also had very good discussion with a number of you. We had discussion with Dr. Fonsell, Dr. Brady, and they have been very informative. I also had a great opportunity to meet with our partners that are doing this great work. That includes Sarah Goldsby, who is the director of the South Carolina's Department of Alcohol and Other Drug Abuse Services. And that's important that we continue to do this work. Clearly, collegiate recovery programs are important, but I want to remind you all, if you look at your clock, it's about 2 p.m. right now. That means that today alone, since midnight, we would have had 3 South Carolinians have died from drug overdose, based on the latest data. It will be about 6 by the end of today. And that's something that I live with every single day. It's important for me to know because it is what is affecting our nation across the country. And the fact of the matter is, just in South Carolina, by the end of this year, there will be about 2,000 people who would have perished. So it becomes very important that we're looking at the great state of South Carolina, or we're looking across our great nation. For the first time historically, we have seen that more than 100,000 Americans have perished in a 12-month period from overdose deaths. That's a serious challenge. We are seeing the overdose deaths hitting a new high, and we also know that our treatment capacity is too low. So the question becomes, how do we create this into what the mayor said, positivity, and how do we create and think about this becoming an opportunity for change? Because if we can create this change at this very important moment, an inflection point in our nation's history, we can begin to end this epidemic. So I'm glad to be speaking with you today because creating this change is going to take all of us working together. We in Washington can't do anything without your help. I know that because I've served at local levels and state levels and as a practitioner. So I understand why it's important to have all of us working together. Let me talk to you a little bit about what the Biden-Harris administration is doing to address this particular epidemic and the critical role that a community like this plays in our collective response to ending this epidemic across America. Let me say a little bit about ONDCP, the Office of National Drug Control Policy. It was established in 1989. I will say before it was Commissioner Kurlikowski, he was Director Kurlikowski, being one of my predecessors. And he would know, but for everyone else who perhaps doesn't know about the office, it does serve as the office that creates and implements the President's National Drug Control Strategy. That means that we coordinate the programs, policies, budgets of 18 federal agencies that work in space spanning both public health and public safety agencies. That means that ONDCP coordinates more than $40 billion in drug policy funds that get spent on strategies and activities to help reduce the drug use and its consequences. Our office also works with Congress in a number of legislative proposals and with communities across the nation. So we've got lots of experts from all over the place. We have people come in from academia as well as from within the federal government. And we try to make sure that we have the best minds in the nation working to develop comprehensive proposals. So we have oftentimes, like right now, we have folks from Centers for Disease Control and Prevention. We have people from CMS, but we also have people from the military, DEA, FBI. So it's a combination of all folks together that help us draft the best way to move forward. And that leads us to work at the very intersection of public safety and public health, and that's what's important. This mission that we're talking about has never been more important because of the lives being lost every single hour, every single day, every single week. As I mentioned, when we talk about 100,000 deaths, you realize that that's losing an American every 5 minutes around the clock. That also means that about 2/3 of these deaths are being driven by a synthetic opioid called fentanyl. That fentanyl is coming from outside of our country into our country. So that's sort of absolutely, I've said before, unacceptable. And it's heartbreaking to see that many Americans dying, especially within the age groups of 25 to 55. Now, we know that the biggest drivers in communities are mainly two. One is the untreated burden of addiction that happens, and the other is the synthetic fentanyl that continues. The synthetic fentanyl, let me just say, starts as precursors from China and ends up in emergency departments right here in Charleston, in Savannah, Columbia, Greenville, and across our communities in the state and across our countries in emergency rooms. But it's important to understand that there's a profiteering mode and motive behind this, right? So all these drug trafficking, oftentimes transnational criminal organizations, they're doing it because they're making money off of it. very small amounts of this deadly chemical is allowed to be shipped easily, trafficked easily, and that's what makes it most lethal, because it is such case. And what makes it worse is that it's cut into other stimulants also, which are also creating problems like cocaine and meth. And I understand from speaking to several of you that meth especially is a big problem, oftentimes cut with fentanyl. Now, what compounds this problem is that not only is it in our communities, but our addiction treatment infrastructure. The inability for people who need the treatment, when they need the treatment, our inability to get that to them. You know, I've been a primary care physician, and I've in towns small as 1,900 and cities big as 25 million plus. I've seen patients. I'm able to help a lot of people get into recovery and have lifelong recovery. There have been some that have not made it, unfortunately, and others who have been, frankly, gotten arrested for manufacturing and dealing. So we've seen the complete circle, if you think about it, is a medical provider within, because I work with law enforcement, I work with medical providers, I work with courts and judges to help address this issue, even as a primary care practitioner. So we need public health strategies that are proven to work and work at the intersection of public health and public safety. So the question really is, how do we do that? And we can't do it unless we all work together at state, local, and federal levels. And I can tell you, I have been very impressed of looking at the ACT force and the work that's happening. The combination of state, local, and federal partners that are looking to find solutions right here. And that's exactly the kind of thing that we need across the country, multiply several folds. And that's how we're going to save lives. Let me talk a little bit about what the administration is doing. So I can tell you, since day one, President Biden has been focused on everything we can do to save lives. This is something that is important to the president, to the vice president, and we have to work and focus on both ends, addressing the untreated addiction as well as addressing and hitting the criminal organizations where it hurts them most in their pocketbooks. And I think it's going to be a both-way approach. We've got to change how we help people. We've got to meet people where they are when they need the help. Part of this is, for example, whether it's harm reduction services or others, try to remove the legal policy and cost barriers that cause people to not get effective treatment for addiction. We announced the first-year drug policy priorities, which have been based in science and evidence and data. These focus on evidence-based prevention, harm reduction, treatment, recovery support services, as well as addressing the supply side. We also focused on racial equity because it is a long-standing issue in drug policy, both in healthcare as well as in criminal justice. And we want to make sure that we are addressing that at the same time. I'll give an example. President Biden has proposed a $41 billion drug control budget to Congress. That's a almost $670 million increase over the previous budget. And it's important that those resources begin to arrive in your communities. And that's the important piece. I heard a lot today about the resource challenge. When we have an epidemic with the speed and agility that it has in killing people, then we have to have resources that match that, and that's exactly what President Biden has proposed. But I can tell you that we've taken a number of steps in between because we're not waiting. We want the Congress to act, but we're still moving on. President Biden signed into law the American Rescue Plan Act, which now provides nearly $4 billion into expanding access to vital mental health and substance use services. That's very important. We made it clear that we're going to provide the ability for providers to have more access to be able to treat, want to be able to treat with buprenorphine, make that at least as easy as writing a prescription for opioids. That's very important. So up to 30 patients, we can do that, and we're still looking at what else we can do on that front. We also have lots of these emergency pandemic rule changes that now allow telehealth and phone counseling and phone treatment, that we're trying to make sure that it continues beyond the pandemic, because that makes sense, especially for rural communities. And DEA, we work with DEA to revise regulations so we can now have mobile methadone vans in rural communities. So that's another access issue that we're trying to help with. But we know we have a lot more to do because we're losing an American every 5 minutes. That's the bottom line. And these are just not numbers. These are parents, these are grandparents, these are children. These are uncles and aunts, and I've attended enough funerals in West Virginia to know that in real life. I've lost enough friends and members of my community to know that. So as we start to present to Congress later this year the President's inaugural National Drug Control Strategy, we've got 4 top priorities right now. And the idea here behind that, the notion is to be able to impact and save lives as quickly as we can, because it is an urgent priority. One is expanding access to naloxone. Obviously, naloxone is an antidote for opioid overdoses. We want to make sure, as a harm reduction strategy, that naloxone is something that everyone has access to, everyone can afford, and everybody who needs it can be administered. Because we know naloxone is available with EMTs, with oftentimes law enforcement, with hospitals, but emergency rooms are not often the only place where overdose happens. It happens in malls, it happens in restrooms or gas stations, and we know that. So we want to make sure that it's available out in the community. But the fact that today is that it's inconsistent, the policy, the legal barriers across the country. So what happens is when you're overdosing, where you live defines whether you get to live or die. And that just shouldn't be the case. And so we're working to produce these model state laws and share that with states to say, hey, what we can't accept, and you should not accept, is this notion that people can live or die just because where they live. And we want to change that. Test strips, fentanyl test strips is important because now the drug, counterfeit drug, and especially pills are contaminated with fentanyl. And a lot of people unsuspecting buy a pill off the street and unknowingly will overdose and die unless they have an opportunity to test their drug supply and know that. Same thing goes for student service programs as part of harm reduction. We know that it prevents overdoses, it reduces the likelihood of getting HIV and hepatitis infections, and it saves lives. So at the end of the day, it's a cost-effective method that supports the work of medical, public health, and public safety agencies. And that's the reason that's important. So naloxone and harm reduction is important. Second piece is treatment. You'll be surprised to know that there isn't as much treatment, maybe you won't be, as out there as we need to. And we need to be able to make sure that there's treatment when people need it, where people need it. That's just not the case today. We all know that. So we're working to expand the ability to get treatment out there. I can give you an example. In 2019, 1 out of 5, or less than 1 out of 5 Americans who wanted a treatment got treatment. So that just shows us that we're not where we need to be, and we have a lot more work to do. So part of this is helpful to get a provider to write up to 30 patients without having to get extra license at this point. This is something we've been able to do. But clearly, for a full-time practice in rural areas, when you have maybe 100 people out of 2,000, maybe more, maybe less, who may suffer from substance disorder, how are you going to choose those 30 patients? So we want to be able to make, once again, access available to people to be able to write that prescription for treatment. It's been too long when these barriers have prevented good providers from helping out. The third one is data. You know, today you can get up and look at your non-fatal COVID cases on your phone from yesterday. Well, guess what? We don't have that for non-fatal opioid cases. You can't see that for yesterday or last week or last month or last 20 years because we don't capture that. It's striking that when I talk to communities like Chicago Public Health Department, State of Maine, others, they tell me that how much non-fatal opioid cases happen, opioid overdose happens, or just non-fatal drug overdoses, as opposed to fatal overdose. So it's important for us to make sure that we understand that every overdose is a cry for help. And as long as we continue to not answer those cries, those people are going to ultimately not end well. And we are losing too many family members of too many families too soon. And that's something we have to change as well. And lastly, I want to say that of the 4 priorities is illicit finance. You know, it's important for us to go after criminal organizations, just like we talk about social determinants of health for health. At the root is profiteering of all the supply side of this. So one of the things that President Biden signed is a couple of executive orders on December 15th that actually creates the ability for us to go after not just the drug cartel leaders, but also their financiers, their enablers, and others. And we intend to utilize that authority fully to make sure that we're making this effort to the fullest possible. I do want to say a little bit about the work that happens on the ground. I know that our medical professionals, health professionals are working very hard. I know that quick response teams are working hard. Our law enforcement partners like state, local, and federal are working very hard. I was really excited to talk with the head of our, the Atlanta, Carolina, head of our HIDA, High Intensity Drug Trafficking Area today, Dan Salter, and we got to speak about the important part that this is such an important work that happens, coordination of law enforcement agencies in order to make sure that we're doing predictive analysis. We're looking forward to seeing what are the patterns of these drug trafficking organizations as well as their illicit finance operations. So I want to thank Dan for the work that you do and your team does each and every day to keep the state safe and people that are here. Yeah. So thank you for that. I know we can improve our access to naloxone, quality treatment, and as has been mentioned before, the issue of stigma. I want to just make sure that we continue to think about stigma, because stigma is something that surrounds all of us and surrounds substance use disorder. Stigma often prevents people from getting the help they need. If they're in work, telling the employer about it, it is something that if we can help get people into evidence-based treatment, it will save lives. And it can be a barrier for people in recovery as well, when they're seeking employment, when they're seeking housing, when they're seeking number of and host of services otherwise too, as well as career opportunities. So we have to be mindful of that. Much of my career has been spent dealing with stigma, whether it's tuberculosis and leprosy in Southeast Asia, or polio, or obviously substance use disorder. And I think just because we don't want to see these diseases in our communities doesn't make them go away. So it's very important that we treat people like people and with the dignity of humanity, and we provide that service to people as a disease, not as a choice. And it's very important that we get people the love and the care and the passion that they need. And that's where you come in. I mean, the whole reason that I'm here today is to be able to talk about this, to be able to talk why it's so difficult for us to help people get access to treatment, expand treatment, reverse overdoses. And it's your advocacy for change. It's your advocacy to make sure that we have high impact harm reduction programs in communities that will save lives. It's your actions and your advocacy for making sure that we can break the stigma around addiction when it comes to the disease. So you can support recovery, just as the collegiate recovery program here in Charleston does, and make sure that people in recovery have the support they need. And that's housing, that's employment, that's daycare, that's food security, and so a barrage of so many other programs. And when we start to work together across the community, I think, as today's panels we're going to hear from, I think we can tell how it's making a difference. So it comes down to, every life is worthy saving, every life is valuable, and we all have a role to play in this effort. So I want to, from the White House, from President Biden's perspective, say that the work that gets done here is important, crucial, and exemplary in so many ways to the nation. I know that I'm going to continue to work tirelessly. I'm in my month 4 of the job, and I hope and I count on you to be able to do the same. I often use the quote that President Biden, when we heard of the 100,000 deaths for the first time, his words were, "We won't let up." And I'll just say that we are not going to let up, and neither will you. So let's keep fighting to make sure that we begin to end this epidemic. So thank you for having me today.
Safe travels.
Thank you so much, Dr. Gupta. We so appreciate your visit to the college. At this time, I'd like to introduce members of our first panel, and y'all can start walking forward. We have Sarah Goldsby, who's the director of the South Carolina Department of Alcohol and Other Drugs of Abuse Services, commonly known as DAODAS. And DAODAS is leading the Embrace Recovery public service announcements we hope you've seen. We also have Dr. Kathleen Brady of the Medical University of South Carolina. She's one of the country's leading and most well-funded addiction specialists and researchers. We also have Dr. Chanda Funsell, who's the director of the Charleston Center, which is our county's alcohol and drug treatment provider. And you've already met federal district court judge, Judge Brucey Hendricks, whose help in establishing the collegiate recovery program is part of the reason why we're gathered here today. So we have note cards on either side of the room for you to submit questions to the panelists individually. And if you place them in those baskets, we will do our best to get those up to the panelists so they can answer some of the questions you may have. And I'm going to take this opportunity to thank Gil Kurlikowski. All his work in organizing this event has been tireless. So, all right, turn it over to the panel. Thank you.
Dr. Brady.
Okay. I think we were each going to start with just saying a few comments.
Oh, okay, sure, yeah. Thanks again to everybody for being here. The Reverend Dewey, who has been at many scenes of tragedies, overdoses, and is there and doing follow-up as well with families, and is a chaplain to our drug court and the state and federal drug court. And as part of that, he does outreach with our participants and their families, and is always ready to help. I'd like to thank Karen Lewis, see her out there, who was with Wood at MUSC, worked with Wood at MUSC, and Dr. Josh Smith, and she is on a volunteer basis, phenomenal counselor to our drug court. She's also worked tirelessly with setting up the peer navigator programs with some of the local police departments. She's here if y'all need her to ask questions. She's always available to help us with our struggling participants or to give support to our team. But I'm thrilled to be here, and I'm going to turn it over to Dr. Brady.
I'm thrilled to be here too. I really appreciate being asked to join my esteemed colleagues here. And I just wanted to say a few words to strike a slightly different tone in this. It is a time of crisis for sure. I mean, and there's been a lot of sorrow and anguish and despair. But, you know, I've been in the field of addictions. I'm a clinician, and I'm a psychiatrist, and I'm also a researcher. I probably spend most of my time in research these days. And I'd have to say, over the last 30 years, we have learned a boatload of things about addictions. We know more about the neurobiology of addictions than we ever did. We know more about the social and the psychological and the environmental precipitants that can either increase or decrease vulnerability to addictions. And we know how those things impact the brain to make those changes. So because of that, really, treatment is improved more than, we have the best treatment now than we've had since I've been in the field. We have life-saving medications for people with overdose. You heard a lot about that, naloxone. We have harm reduction strategies with proven efficacy. We have psychopharmacologic treatments as well as psychosocial treatments, as well as lots of developments in the device area, both the use of TMS, for instance, to help people with cigarette smoking has been FDA cleared, as well as the use of smartphone apps with some really cool ways of sort of reminding people about triggers while they're out in their working and living environment. So, I mean, we have never really had a better array of things that are evidence-based that can treat addictions. The big problem here is access to those who need them. Only somewhere between 10 to 20% of people with substance use disorders are in treatment. Partly, the stigma of the disorder is a huge problem. The stigma of the disorder at the level of our government, I think, makes it an underfunded. We're terribly underfunded in terms of treatment, and we're underfunded compared to any other disease that I know of. In addition, the stigma makes it hard for people to seek treatment. We heard Dr. Gupta talk about how that happens. People are afraid to go to their employers. They don't want to talk to their parents or their loved ones about it. So we really need to make treatment more accessible at the time when people need it. It needs to be really treatment on demand. When people want and are ready to accept treatment, it needs to be there for them, and we do have good treatment. So I think, to me, this is a lot more of a hopeful and optimistic message than if you had a disorder that was killing people, but we had no idea what to do about it. That's not the case. We know what to do. We just need to get it done. So I hope that's the call to action that we're going to be working on as we leave here today.
Thank you, Dr. Brady, for sharing that important message on stigma and how that impacts access to care. As I was introduced, I'm Chanda Fensel, and I'm the Executive Director of the Charleston Center, which is Charleston County Government's Department of Alcohol and Other Drug Abuse Services. And we offer a full continuum of care, ranging from withdrawal management services all the way through outpatient services, opioid treatment program services, as well as working with our treatment courts and programs in our detention center, assessment center, you name it, we try to do. And I'm a huge proponent of harm reduction. I've been working in this field for over 25 years because, like so many other people's stories, I grew up in a family that was impacted with someone who had a substance use disorder that ultimately died from their substance use disorder, and throughout the course of their disease struggled with interactions with the criminal justice system. And so this became a passion of mine as a young person, and have continued that into what I do now. But I couldn't do any of the work that I do if we didn't have these incredible collaborations that we have in this community in particular. When I talk with my colleagues across the state and my colleagues across the nation, I'm amazed at what we have here in Charleston, South Carolina, that other communities across our country do not have. Our partnerships are incredible. As we heard oftentimes today, we've heard the term force multiplier. We can do so much more together than we can do alone. We can't tackle this problem in silos, but it's only through blanketing our community together can we make a significant impact. And I look out in this room and I see people that you'll hear from later today in other panels that are boots on the ground that do incredible work. We'll hear from Matt Hughes, one of my favorite people in North Charleston Police Department, who works closely with my program administrator, Caitlin Kratz, to get Narcan out into the community and getting it into areas where we necessarily wouldn't go. And, you know, he's known as the Narcan guy. And it warms my heart that never before would I think that we would have such an incredible collaboration with law enforcement, and that would be a shining moment in their career as well, and that we can partner together. We really tried to do everything that we can in Charleston Center to help support the priorities within the ONDCP's policies, first-year policies. You heard Dr. Gupta talk about the importance of getting Narcan out into the community as well as fentanyl, and through the efforts that we have in our community, Charleston Center, Center for Behavioral Health, Low Country Favor are just some of the organizations here, Wake Up Carolina, some of the organizations here that help us get all that Narcan out in the community to save lives. For example, just within Charleston Center, we've been able to hand out, since September, over 700 fentanyl test strip kits, and we've also been able to get out almost 5,000 doses of Narcan. And while that seems a lot, it's not nearly enough. And I'm so thankful to have the community collaborations that we do to make sure that we can get our reach out there to get as much Narcan out in the community as possible. Another thing that you heard Dr. Gupta talk about was racial and ethnic disproportionality and disparity. And I'm really fortunate through our work with the Criminal Justice Coordinating Council that there's a few members here in the audience that are part of that, that through those efforts, we're able to look at racial and ethnic disparities and disproportionalities and people impacted within the criminal justice system that have behavioral health issues, and being able to do deep dives into that data to look at trends and figure out how we can make a difference. Also, I'm super excited that last week we were able to work with our treatment courts, mental health court, adult drug court, and veterans court, to put in an application to be part of a learning collaborative with SAMHSA's Gain Center to look at treatment courts and look at inclusion and equity with treatment courts as far as racial and ethnic disproportionality and disparity. So we're diving into that as far as treatment access and making sure that everybody has the ability to access the care regardless of their socioeconomic or demographic background. And then the other important collaboration that we have that I really love is our work with ACT Force. When I first walked in the door for our very first meeting, I had no clue what to expect and never would have imagined we'd be where we are at today. And I think one of the powerful things that we do is looking at data together and how we can identify trends and make significant impacts in our community. For example, through the Overdose Detection Mapping System, ODMAP, being able to identify hot spots when we have spikes in our community, trends, locations where we need to have targeted community prevention efforts, and pairing that data with data collected through dispatch, and being able to identify our food and bev and hotel industries that are really struggling and how we can be out there to support them. And working on grants with CPD and Rachel Lefebvre and Chelsea Taylor, and working on bringing peer support services into our police force, and working on adding the critical incident management system so that we have another tool to make sure that we can follow up with individuals when they've had an overdose, so that we can make sure that we can connect with them, get them information, get them connected to treatment, get them a Narcan kit, or just be there as a support, connecting them with chaplaincy services, whatever they need, and supporting the families. So there's such incredible work in this community, and the shift that we've had from moving from trying to arrest our way out of it to moving to a public health model is long overdue, and we need all of you to work with us to continue the efforts, because we know we have a lot of improvements to do as far as the treatment on demand access, getting more Narcan out, changing the attitudes that are causing deaths. We're all here because we want to make sure that we don't lose another life. And when we have resources there, but attitudes are the barriers, I can't tolerate that. And I hope that you wouldn't tolerate that either. You know, one of the things that Dr. Gupta talked about as far as harm reduction was Narcan, fentanyl test strips, and syringe services. We're really good at 2 of those. We still have so much more work to do on getting attitudinal barriers removed so that we can have a strong syringe service program here that's open and public to help benefit and save lives. So that's what I'm passionate about, and I hope that you all will be as committed as we all are up here to continue these efforts in our community. Thank you.
So good afternoon. My name is Sarah Goldsby, and I'm the director of the South Carolina Department of Alcohol and Other Drug Abuse Services. We are a state agency in Columbia. But every state has a single state agency or a single state authority that manages the publicly funded addiction service system that embraces the continuum of prevention, intervention, treatment, and recovery. And so our role is really to be an administrator of the federal funds, the pillar of that being the Substance Abuse Prevention and Treatment Block Grant Funds, which is a $1.8 billion federal formula grant that Dr. Gupta, some of the funding that he oversees across the administration. South Carolina's portion of that is about $24 million annually. And so, you know, is it enough? I guess that's a question, you know, and something that we've been talking a lot about over the course of the day. But we do also manage the other opioid and substance-specific grants and federal funds that come to the state, ensuring that these programs and services, many of which Chanda just described, are actually available, and supporting things like the Collegiate Recovery Program here at College of Charleston and our emerging recovery community organizations across the state and in our colleges and universities. Some of what has been built here at the College of Charleston, we've been able to spread into HBCUs across the state and our technical colleges and Gamecock Recovery now. And so that's our role, is to sort of help things develop, learn from them, and spread and scale what we know works. And that's another role that we play when it comes to promoting and ensuring quality. Is really promoting and ensuring evidence-based practices. And what Dr. Brady underscored is that the science is there. We know what works. And so making sure that we're adhering to the practices that science say will have an impact. And with that, we offer technical assistance and monitor and oversee a lot of that programmatic work. What we touch is in every county of this state. And actually over 67 treatment provider locations, 54 providers. And what we have to say about that is every single county is different. Every single city is different. And while addiction and the problems of addiction look a lot alike, communities have unique dynamics that we have to work with. And so along with that, we really just develop a lot of relationships and have unique relationships with those providers to understand what's going on at the ground level, having a lot of information flow and data flow with the boots on the ground so that we can know how best to support and allocate resources. In addition to that, our main role at the state is to promote coordination across state government, because as you know, addiction touches every single sector. And so with that, we have partnerships with our Department of Mental Health and liaisons, staff that work between our agencies, so that we're building programming and services that address both mental health and addiction disorders. We have liaison with the Department of Social Services because we know, addiction impacts families in a way that puts children and families in the social service system. And so again, education and program development with that system that really supports families that have been impacted by this disorder. And then our Department of Health and Environmental Control. We work day in and day out with our Department of Health, especially around the data And with some of these intervention services that we've been talking about, particularly our naloxone distribution, while we've been able to support the procurement and the distribution of most of the Narcan in the state, we could not do that without our other state partners at the Department of Health. And of course, we have to say, our law enforcement friends, our state law enforcement division, and Chief Keel and I are counterparts. We are on the phone every single day talking about the narcotics in our state and the data and what we're seeing, so that we know how to best support each local municipality and county the best way that they need that. So I think, there's a theme today, and a theme to many of the conversations that you've heard and what you heard from Dr. Gupta, and that's really collaboration. And the key to addressing the addiction crisis is really centered in that, and the partnership developed across sectors and across the federal, state, and local governments. I think we can't say enough about what is happening here. Charleston has been a leader, and I think that centers around Judge Hendrick's leadership and the Act Force development. It's truly a model that we've been hoping that we can work on scaling and spreading to other places, because Charleston is really leading the way, making significant impact, and that's because of the coordinated effort that you have heard about from the panelists today. So I will say one last thing, and that is I hope that this is being broadcast to many students. And if you are interested in working on addiction, the workforce needs you. We need students interested in addiction research, students interested in treating addiction, students interested in prevention programming to come and join us. And I can't stress that enough. So please reach out. Please find out how you can get to work with us. And I'll end there.
Judge, I think it might be helpful because people would take some questions from the audience, and I would start with the first one. I promised you no surprises. So I'll just surprise Dr. Brady with a question and say that you mentioned an app, and it looks like there's some people here that may be more technologically familiar with apps than I am. And you mentioned an app that could warn people about triggers. Maybe if you take a few minutes and explain what that might be, Dr. Brady.
So there's a couple of different phone apps that are now available. Obviously, they need to be linked with treatment services. You wouldn't just give somebody the phone and say, download this and do it. But through a careful interview with a counselor or therapist, you figure out where people's high-risk situations might be for using. You figure out what their internal mood states might be that usually come right before the use, and so the apps will do a variety of things. One app that we're using right now in a study actually makes available cognitive behavioral therapy, just little modules every day, but then it does follow people. There's others that follow people throughout the day and ask, are you craving now? Or if they are craving, they're allowed to, what they're supposed to do is hit a button and it will actually take you to a counselor or take you to somebody that can provide help right away. But give you reminders during the day. Again, they can be set up, as you all know how apps work, they can be set up in a number of different ways, but they might give you reminders or little pep, good job throughout the day. But also, if the settings are right and people are headed into situations where they've been known to use in the past, it might send them warnings like it looks like you're heading into trouble, you may want to rethink this. It might give you a number to call, that sort of thing.
Questions? Dr. Cabot, after you.
Hello, I'm Jerry Cabot. I'm the former Dean of Students at the College of Charleston, so my question will be framed around students. But before I ask my questions, I can't thank you all enough for the commitment and the devotion you've given to the state of South Carolina. And it makes me so proud to be a resident of South Carolina, to know that we have folks like you who are making the commitment of time and passion. But so let's, treatment on demand. If I could ask you about a scenario and how that would work, let's say for a college student who's already 6 weeks into the semester, therefore no money back on tuition, very reluctant to talk to family about their problem, and thinks about outpatient treatment, but could they really devote the time that would be necessary to that treatment and also try to hang on to the classes? Or are we at a point where we really tell someone, postpone the education and concentrate on your health and recovery? Because that's what I found out. It would usually be about halfway into the semester. And so no institution I know about would give any sort of tuition refund. And then to have that conversation with family, even if that conversation could be had, was so difficult. And then to explore outpatient with them and to hear about the time commitment and the times of day would blow any kind of classwork out of the water. So I just, how would that work?
I'm happy to tackle that question. I was actually having that exact conversation with Director Goldsby today. So whether the person would need outpatient services or something that would require more time commitment would be determined through a thorough comprehensive assessment to determine the severity of their use disorder. But if it was somebody that strictly needed outpatient therapy, one of the things that we learned through the pandemic was the benefit of telehealth services. And so we were talking today about group therapy is not for everybody, even though it has been the gold standard of care for substance use disorders throughout the years. We are moving more towards a technological approach to treating multiple situations. I think I saw my doctors for the first year only on Zoom or a FaceTime call, and we also, as Drug and Alcohol Commissions, increased our capacity to provide telehealth to individuals in the community, and will continue to do so moving forward, even when we get to the endemic period. And so when I look at an individual like that, we want to meet them where they're at, and so I think it's imperative as treatment providers that we adapt to meet the person's needs and not expect the person to adapt to a one-size-fits-all approach to treatment and recovery. And so when I hear that story, I would think, wow, that would be a perfect candidate to be able to participate in a telehealth program to support them, to see if we can balance all of their needs. And then if we found out later down the road that it was so severe that that wasn't the optimal situation for them to get where they needed to in their recovery, then we could look at something else. But for treatment on demand and meeting a person where they're at, that person would be a perfect candidate for telehealth.
And I just have to say, we've gotten so sophisticated in telehealth, necessity being the mother of invention. I mean, we can do urine drug screening and test it with, osmolality and temperature. We can do a CO monitor if it's your smoking cessation. We can do a breathalyzer. We can even do orthostatic blood pressure over telehealth. I mean, it's just gotten, there are so many things that can be done over telehealth that we never imagined doing, but.
Dr. Cabot, she well knows the school year schedule. She understands that spring break is right around the corner, and things tend to ramp up for me around that time.
Anyone else? Yeah. Okay. Hello, my name is Marcus Mcdonald. I'm lead organizer of Charleston Black Lives Matter, also in CJCC, and I'm also a community organizer at Eastside Neighborhood Association. So we do see a lot of these cases. So I was wondering, and there's a question in regards to, it was mentioned about the racial disparities and what we've seen in the laws. It's not always been, a pat on the back. A lot of it's been real carceral. So I was wondering, and it was also mentioned about some of the partnerships with law enforcement. So I was wondering, is it I don't know the best way to word this, but is there a concerted effort to also provide safe spaces for people who maybe suffering from addiction but not feel comfortable entering a space that has high law enforcement visibility in fear of they might get retaliated against or have to suffer through more criminal justice issues. Is that safe space available, or is that being developed?
I'm happy to tackle that question too. That's a great question, Marcus. And so I think throughout our community, there's a number of recovery organizations like Wake Up Carolina, like Favor Low Country, and there's a few others in our community where people can go to. That's a safe space. That's not a law enforcement presence. There's all recovery meetings and other mutual aid support groups in the community that people can go, and those are definitely safe spaces. And also, when a person enters treatment, we're bound by federal law through 42 CFR Part 2, which is confidentiality standards around drug and alcohol treatment. And so we provide a protected environment for a person, and if they had law enforcement involvement in any aspect of their life, they would have to sign a consent of information that would allow us to interact with law enforcement. We would never do that ahead of a person's consent to do that unless they were committing a crime or were threatening harm to themselves or others. And so when a person enters the room for drug and alcohol treatment, it's a very protected space. Yep.
Dr. Brady, this question is mainly for you, but it's for anyone else on the panel as well. I've heard you talk some about the issue of stigma and how there's research around stigma and understanding it. I was wondering if you could speak to that specifically in the context of how we might go make some efforts towards mitigating stigma.
Yeah, I would say that there really hasn't been, I think there's really a dearth of research in this area in general, and it's an area I would love to see more dedicated study of. But the few, articles I've been, I think I told you, I have to give a plenary at ASAM about stigma, so I started reading all I could find, and there, it's just amazing that there isn't much data. There's a lot written. So, but one of the articles I found most helpful talked about a couple of things that could be done. One of the things it said was that we really do need to change our language around the way we talk about addiction, and that it's substance use disorders, and people aren't clean or dirty, and it's relapse and not, so really using language and they're not addicts, they're people with an addiction or people with substance use disorders. So language was one thing. They also talked about how important success stories are, how important it is that people know. I mean, everybody knows somebody that was a tragedy because they hit the newspaper, everyone knows about it, but there are, sitting in this room, there are many, very productive, high-functioning citizens who have recovered from addiction. So there's a ton of success stories out there, but we just don't know enough about it. One of the other things they said is that, really, if you've got successful treatments, you've got to talk about it. So a disorder is more likely to be stigmatized if people think it really is, it's a death sentence, there's nothing that can be done, we just don't want to. So if we've got successful treatments, we need to really promote that. This is not a dead-end situation. There's a lot that can be done, and there's a lot of people that haven't been helped by treatment. So those are a few things that are recommended, but I'd love to see a little more research done in that area.
And even though more research is needed, what we know is what Dr. Brady mentioned, and the language and the success stories and the storytelling and celebrating recovery, celebrating the people, the hundreds of thousands of people, almost 500,000 people in South Carolina living lives in full recovery. Holding that up and celebrating that through storytelling, through the media, at our dinner tables, in our churches, everywhere we go, that's really what is going to change the narrative, right? And away from doom and gloom, and really building that support around people who have overcome. So I will just put a plug in for embracerecoverysc.org, which has more information on the language that can be downloaded with a toolkit and a pledge to use the language. A lot of information about what recovery is and what that means, the role of recovery community organizations and what they do for families and individuals. And I think sharing that information and getting those messages out is really going to shift things for a more hopeful way that we move ahead together on the issue.
This would be a question for Judge Hendricks and all the others. No surprises. But you've mentioned celebrating recovery. And so we've seen the recovery walks across the country, the recovery walk across the Brooklyn Bridge with 40,000 people in recovery. We have our own recovery walks. Judge, would you start, because I know you've attended a number of the recovery walks that are here locally, and we would all hope that they would get a bit more attention. But and then for the rest of the panel, if you all would chime in on celebrating recovery and how we're doing here.
I don't know if anybody's here from Mount Pleasant PD. Blair, are you here? No, I don't see him, but I know there had been, and Shonda, you participated in the recovery walk across the bridge, Chief Ritchie. I don't know if that was the Mount Pleasant PD that spearheaded that. Do you remember?
It's actually it was a coordinated effort between our Favor Low Country, Wake Up Carolina, Mount Pleasant Police Department, and Ben's Friends, and we have a Low Country Recovery Coalition, and so every year we made it our annual commitment to celebrate recovery by doing the recovery walk and having usually a band that is a band in recovery, and sharing messages of strength and hope from people that have long-term recovery. And it's started out small and has grown into be such a wonderful event that really does celebrate recovery and highlight the importance of all of us community wrapping together to support our recovery community.
So I'll look into that and see whether or not the pandemic has temporarily stalled that particular event, but it might be a good event for Act Force to talk about and promote and participate in. I know we did, but it's been a couple of years ago, and I think that exercise is probably good for one in recovery, but I would defer to Dr. Brady about that. Yeah. Produces some kind of chemical,
BDNF, which actually, there you go, brain-derived neurotropic factor that actually does help you generate new brain cells. It's exercise is really good for you.
It's a high, right?
Yeah.
Okay.
I just wanted to reiterate about the recovery walk. The very first year we had it, and the subsequent years, I think the most powerful thing is when we talk about stigma, we had the mayor talking about family impact. He stood as, I am the mayor of Mount Pleasant, but I am also a family member in recovery. We had our chief of police say the same thing, and then we had a public figure that was on the news every night, and he shared that he was living in recovery. That was a lot of power. That was the very first one we had, and it gave power to where there are faces saying that we are recovering. And every year it looks a little different, and it gets bigger with the partnerships and then the resources and all, but it is a really powerful thing that the dream that we've always said is one day maybe we can get the purple lights going over the bridge so that we can do it at dusk, and then it would really be a bridge to recovery walk. But it's just a really neat thing to talk about that very first year.
Well, thank you to our first panel. Our first panel Our second panel, if you folks could approach the stage. We've already heard about Matt Hughes. He works with the North Charleston Police Department. We also have Francie Daniel Austin, who's the assistant attorney for the city of North Charleston. We have Jamie Shane, who is the federal prosecutor as an assistant United States attorney. Rachel Lefevre from the Charleston County Police Department, and Judge Irv Condon, who is the presiding judge of the Charleston County Drug Court.
Stage though. In the back, Jack.
Sure. Good afternoon. I'm Matt Hughes. Sorry, I feel like I'm screaming. I'm Matt Hughes with the City of North Charleston Police Department. Been there for 20-something years now, and seen a lot of things go on in 20-something years. But obviously, with just like the rest of you in this room, never anything like we're seeing now. So with that, we've realized over the last couple of years that we needed to make significant changes in the way we address the law enforcement approach to a crisis such as this. We realized pretty early on that we can't arrest ourselves our way out of this crisis that we're in. So we've had to find ways to work better with our citizens to guide them toward treatment and not try and force treatment or force corrective behavior or anything like that. So we've been honored to form a number of alliances and a number of groups, especially the ACT Force. We were lucky enough to get involved with that back in 2019, I believe, early 2019. And as part of that, we as an agency, myself and Francie Austin, and a number of others at the city worked on a program that we called Paths to Recovery. And in that, we tried to find as many resources as we could and compile them into one easy-to-find location and spread that through the city, or to as many people as we could, as fast as we could. So we went a little bit further with that after we realized that part of what we were doing involved a lot of mental health issues that we weren't addressing, or we weren't getting that voice to the crowd that needed to hear it. So we were lucky enough to get a liaison from the Department of Mental Health, Bill King, who's been with us for a while now. He does a lot of work with us, spreading the education and awareness of mental health and the stigma that goes along with a lot of that. We've hosted training for our department, and other departments have come, working on the issue of stigma, the language of addiction, and working on that, how to speak with people, not run them off before you get into a good conversation with them to find out what it is they need. And like a couple people said with the harm reduction, the Narcan training has been it's been huge for us. We've met a lot of people through it. We've gone a long way from where we started, with a lot of help from the Charleston Center. Caitlin and Dr. Funsell, we couldn't have done any of what we've done without them. So we started doing traditional classes, like in a classroom type setting, or as best we could, but we weren't reaching the real target audience, the people that we really needed to get it. The people that were coming is great that we were getting it out there and getting the education and awareness out there. But I felt like there was a group of people that we really needed to kind of get a hold of and get this where it needs to be. And one, if it's at all possible, and I don't mean to offend anyone, but if there could be one blessing that came from COVID, it was the fact that we couldn't do those in-person classes anymore, and we were forced to find another way. So in doing that, going back to Caitlin and Dr. Fonsell, we were able to get with them and do Narcan training in the streets and go to hotels and parking lots and homeless camps and anywhere we could find someone or a group of people to get these classes together and get them underway. And in doing that, we've gotten, I have no idea, no clue how much Narcan we've put in the streets in the hands of people that will use it or know somebody that will use it. So that's been huge as far as what we've been able to do. But like Dr. Gupta said earlier, the number of people that will die in South Carolina today, or in the nation today, it's the reality of it is on the way here. I got notified of a death on the way to our meeting here today, and we've had 3 in the last 2 days, and those are all suspected, nothing confirmed yet. But the reality is, I'm not telling anyone in this room. You're here because you know, but it's happening and the ripple effect of that is who knows how many people have been reached by that or been touched by that. So in 2021, just real quick, and then I'll be done. 2021 in North Charleston, we have 82 suspected fatal overdoses just in North Charleston in 2021. Thus far in 2022, we have 13 suspected. So the numbers are crazy, and the Narcan and the education and awareness we're getting out is helping. We just have to keep pushing, keep the fight. 341. And let me go back 1 second. HIDA and the help we've had from them with ODMAP, that's been crucial for us on the street, knowing where we need to get, where we need to push resources and where we need to push Narcan and mental health, being able to follow the information that we're getting from HIDA through ODMAP. It's huge in getting us our numbers and where we need to get. And that's really all I had.
Good afternoon, everyone. My name is Rachel Lefebvre, and I'm the PARI Outreach Coordinator at City of Charleston Police Department. That first thing in my title, PARI, that's an acronym for the Police Assisted Addiction and Recovery Initiative, which is a nonprofit organization based in Massachusetts that partners with law enforcement agencies all across the country to create non-arrest pathways to recovery. PARI essentially started because police officers have this unique front row seat to the opioid epidemic. Every day our officers are encountering community members who struggle with substance use disorders. Every day they're responding to overdose calls. But what's happening after they respond to that call? That's where PARI came in, trying to find ways to turn those encounters into outreach opportunities. So bringing it back to the City of Charleston Police Department, they started their partnership with PARI last year, which allowed them to bring me on as an AmeriCorps Vista to help coordinate a new post-overdose follow-up program. This has kind of been the first program in our opioid response in the past year. And this program was basically started with 3 goals: to overall prevent overdoses, to support citizens who struggle with substance use disorder and their loved ones by connecting them to treatment options, support groups, and harm reduction supplies. And lastly, we want to divert people away from the criminal justice system and toward a path of recovery. So a little more about this program. Essentially, when one of our officers responds to an overdose incident, that case report is given to our outreach team. We have a dedicated community outreach officer who is looking into that case and determines the best ways to connect with that person. That outreach officer ideally will actually go to that person's home, visit them and their family. They can give them a Narcan kit, train them how to respond to an overdose, and have that harm reduction approach of meeting the person where they're at So if they're interested in a support group or a recovery option, we have all of those local resources to refer them to. And I'm happy to say that within the first 8 months of this program, we were able to give 33 direct referrals to treatment and support 13 families by giving them resources for their own recovery as a family member of someone suffering from a substance use disorder. Outside of this post-overdose follow-up, we also focus heavily on Narcan distribution, just as North Charleston does. We have a great partnership with Favor Low Country, who allows us to distribute their supply of Narcan, and soon we'll be adding fentanyl test strips onto that. We use OD Map to identify which neighborhoods in the city are suffering the most from overdoses, and we use that to target that Narcan distribution. And in 2021, between the post-overdose outreach and this community distribution with Favor, we were able to give away 45 Narcan kits throughout the city for no charge, which we thought was a great accomplishment. Moving on to kind of beyond the city and what we do with Act Force, collaborating with our neighboring law enforcement agencies is very important, because maybe someone overdoses in the city, but they live in North Charleston or Mount Pleasant. How are we kind of connecting these cases and making sure that we're able to still be visiting people and supporting them along the way with recovery? So we're very happy to have received a 3-year grant from the Bureau of Justice Assistance to help us strengthen our collaboration with the ACT Force and neighboring law enforcement agencies. This grant is going to allow us to purchase a new software that will help us track overdose cases in real time and also follow through with outreach efforts, so we can see where we are referring people to, such as the Charleston Center or Center for Behavioral Health, for example. This grant is also going to allow us to hire 2 full-time peer recovery specialists. We think this is great because some of you might be thinking that someone just overdosed and a law enforcement officer is knocking on their door. Maybe they don't want to talk to them. So having that peer recovery specialist with them kind of creates a safer environment, and you have someone with that more expertise. And it's also going to help the law enforcement officer kind of show, we're not there looking for drugs, we're not there trying to get you in trouble, we're there to support you and create a relationship with you. So we're very excited to add those 2 personnel to the team. And overall, we just think this is going to help us serve more people and just have the capacity to have longer ongoing relationships with people in our community that we know are still struggling with substance use.
Hi, I'm Jamie Shane. I am an assistant United States attorney, and I'm in the narcotics division. There are 4 primary ways that we at the U.S. Attorney's Office are addressing the epidemic. The first way, and this is how I got involved with substance use disorder, is through the drug court. The first federal drug court in South Carolina started about 12 years ago, and that is mind-blowing because the state has been doing drug courts for many, many years. But it wasn't until Judge Hendricks began the first pilot drug court program here, and it was the first one that we had. I believe at the time there was only about 10 in the whole country. Since then, there are now drug courts in all of our major cities where there are federal courts in South Carolina. And that really started the conversation in our office with recovery. We started looking at who are individuals that their criminal behavior is fueled by a substance use disorder, and what are ways that we can help in the ways that even before a conviction, even certainly before jail, that we can focus on rehabilitation so that people can go from a place where criminal behavior is an outpouring of substance use disorder to fruitful lives contributing to society and teaching many of us about what this looks like and what it can look like. From there, I will talk about the more standard, what you would think about from a prosecutor, that is traditional prosecution. So we're focused on the sources of supply. Where are the drugs coming in? This is the most profitable criminal enterprise in the United States. Where is that money going, and how can we stop the tide? So we're looking at, someone mentioned earlier in the earlier panel, transnational organized crime. So I'm on the Organized Crime Drug Enforcement Task Force, and we're looking for those organized crimes that are bringing this poison into our communities. And it's interesting, the higher up in the chain you get, the less likely it is that people are using the substances that they're distributing, because they know that it is deadly. And I think of this phone call. We were listening to jail phone calls, and one of my sources of supply was talking to another individual and saying, "You won't believe this. The nurse told me that I am coming down from heroin. Can you believe that? Because I use gloves, I use a mask. Every time that I package that stuff," I didn't say stuff, I make sure I don't get anywhere near that, because that stuff kills you. And it was such a, man, it's just so sad to see that people are so motivated by profit that they're willing, that they're really willing to take people's lives. I work with the DEA, FBI, HSI, and then all of our local partners here, the City of Charleston, the City of North Charleston, the Sheriff's Office, Mount Pleasant. They each have task force officers on our Organized Crime and Drug Enforcement Task Force, and they do an excellent job in partnership here. That is the organized crime profit type of prosecutions that I work on. The second type of prosecutions are victim-oriented. So we look at people who have overdosed from drugs, and we try to look back and find where those drugs came from. And we try to be very specific with those types of crimes when we prosecute them. We look for people that have distributed drugs to multiple people who have died. Who are also stealing money from the individuals who have died, where there is some kind of profit or other motivation, because it's easy to be in that chain. So that's one type of victim-centered crime that we look at. Another is human trafficking. Human trafficking in the federal system is using force, fraud, or coercion to cause someone to engage in commercial sex acts. We're seeing an increase, and have been, in people, traffickers, using substances to coerce others into trafficking. So creating an addiction in someone by giving them drugs, and then taking those away and forcing them into commercial sex using those drugs. So those are the two types of prosecutions that I look at in the Narcotics Center Division. And then the last thing I want to talk about is the Addiction Crisis Task Force. We have been a partner from the beginning with the Addiction Crisis Task Force, and I cannot express how important that has been to our office and to the ways that we think about crime, the ways that we think about who are we dealing with, who are the people that are coming into contact with the criminal justice system, and thinking about the language. And what other opportunity would I as a prosecutor have to hear about what damage language can cause to citizens who are trying to recover, who are trying to find rehabilitation? I know I wasn't taught it at law school. And so we're just even that one topic, I mean, there's so many we could talk about, but that example that came up earlier, these partnering with across lines with law enforcement, with a group that you're not normally in, gives you the opportunity to change the way that you think. And I'm incredibly grateful for having the opportunity to work with Dr. Funsell and many others who helped to teach me that even my language can impact what an impact that can have on others. Thank you all.
Thank you for having me here today. It's great to be back at the college. I went to Bishop England High School, so that library over there is where I went to school, and could actually come over here and take classes, and I went 1 year here before I went up to Clemson. My name is Irv Condon, probate judge for Charleston County. I'll try to be quick. Chaplain Dewey said he's got a pickleball game, so I got to get him on out of here. It's a beautiful day. I wish I had Arnold here. Arnold is one of our graduates. He works here at the College of Charleston. Many of you may know him. He works at the basketball games there, and he just speaks wonders of drug court. He is one of our early graduates. We started drug court back in 1999. We went down to Miami. Judge Goldstein was the first judge to start that. We brought him up here, and he sold it to our public defender and our prosecutor. 2002, we started the mental health court. Judge Curry heads that up, and she'll be talking a little bit later about mental health court. But we're just trying to help individuals. And we recently started a veterans treatment court. Judge Cooten is covering our drug court today, otherwise he would be here. He heads that up. He's a veteran. He's also a College of Charleston graduate. But we're just trying to help individuals. We got those 3 programs. We also, probate court has jurisdiction over states and trust. We do marriage licenses. Dr. Gupta, the other Dr. Gupta, Sanjay, got a license from us. Not this Gupta, but I asked him about him. They're not related. But anyway, we also do civil commitments for involuntary commitments for alcohol and drug and mental illness. We work with the Charleston Center, Dr. Fonsella's group. We work with Charleston Dorchester Mental Health Center. And we do about 1,800 commitments a year. And so that is probably where we're trying to take these tools from drug court and apply them over in our court-assisted treatment. Judge Hendricks didn't talk too much about drug court, but just to give you a little background on it, it started, I guess, down there in Miami. They have key components. We invite you to see our court. We are on Zoom right now. It's Wednesday afternoons, 4 o'clock. Judge Curry heads up the mental health court. That's 10 o'clock on Thursdays. Judge Cooten is heading up the Veterans Treatment Court, and that's Tuesdays at 4 o'clock. So if you want to come see it in action, it's a team approach. You got a prosecutor there. You've got public defender. Before court, we do staffing. We have treatment, probation. Chaplain Dewey is our outreach person and helps us greatly. We've got voc rehab. It's a holistic approach in trying to help individuals better their lives. They're wrapped up in the criminal justice system. They shouldn't be in jail or prison. We need to get them out, making them productive citizens. So we're just trying to help them, to help themselves. Generally, most programs have phases. We have like 5 phases. Drug court will take about a year. Mental health court, maybe a little bit shorter. Veterans court's about the same period of time. Many of these individuals have never had a judge reach out to them and say, good job, or give them a certificate as they advance through a program. And so we find that incentives work better than sanctions. And so we try to change that behavior. We're not there to punish. We're there to help. And we've changed many lives. And I always laugh. I think one of the days Judge Hendricks visited us, we had our speaker, graduation speaker, was Chief Mullen of the city of Charleston. His house had been broken into by Brian. Brian broke into his house when he was high and addicted, not realizing it was the chief of police house. They're not always the smartest. But Brian came that day and gave a check to the chief for the jewelry that he had stolen and pawned and paid him back. But that's one of the best pictures, I think, is seeing Brian there with the chief and just seeing that change in that life. We can't change or everyone, but we can help or try to help as many as we can. And through drug court, mental health court, veterans court, we're trying to do that. And we welcome you to come visit us, or if you have any questions, just let us know. And next time, Wood, we're over here, I'm gonna get Arnold here to come in and speak, and he's such a powerful speaker and shows you the beauty of recovery. Thank you.
Hi, I'm Francie Austin. I've been with the City of North Charleston for about 11 years now, which is hard to believe, and I don't want to go back over all the great points that Lieutenant Hughes has made, but we have been partners along on this journey, and one that I'm very grateful for. We have a great friendship and have learned a lot through all this. He touched on basically when we first got started with Act Force, I think I was brought on as a lawyer to kind of be a liaison between the courts and the prosecutor's office and just the different agencies. And we kind of, both Matt and I, felt very overwhelmed with all the help that these people needed. And we found, we kind of felt helpless and that this was just too big of a problem. And
we started off by realizing that we did not have any of the resources to do any of this, nor did we have the expertise, nor were we equipped in any way to help these people. But we started finding through the ACT Force the people that were able to. And we started making connections and relationships. And I look out in this crowd and I'm so grateful for all of these people doing such wonderful work. And we just continue, not only to grow and build the ACT Force, but we're stronger together because of it. Matt mentioned, sorry, I'm not quiet to begin with. Matt mentioned our paths to recovery, and I would love for anyone to come and take these because we ordered a ton, as you can see, and I think this is one of 5 sleeves. But we found that it's easier to have a website that people can go to with a QR code. I mean, even people in dire straits have cell phones these days. But we found that we could add all the different resources to this card, and we, in hopes, I've made a quick list. We have Favor, Narcotics Anonymous, Ben's Friends, Wake Up Carolina. We even have insurance and funding resources on here. We have support groups for families on here, and we did find, I guess the point to all of this is we found that we don't have the funding as a police department and city to do everything, but there are so many people who are highly qualified and want to help available. And that's where Matt and I see our biggest impact being made. So if anybody wants them, we'll have them at the end.
Questions? Jerry.
Okay. Hi. Again, thank you for everything that you do for the community of Charleston and beyond. Can you talk to us a little bit about housing? I've heard a lot from when I've talked to people in recovery that where they are, they know is not a safe place to be, a healthy place to be, but they can't imagine where to go as they start their journey for recovery, and they can't afford, let's say, complete inpatient recovery location. And so I'm sure you all have thought about this, or it's one of the pieces of the puzzle.
I don't mind speaking to that. I should have mentioned on this card, which I didn't pay her to say that, I promise. There are also sober living houses that you have, and also we have like the Alcohol Anonymous, Heroin Anonymous. There's a whole list with websites and phone numbers and who to contact. And there's also this Palmetto project that I didn't even know about, and it is a state-funded project, and it's I'm no insurance expert, but they help you find insurance the state offers that you might not be aware that you have. And a lot of times they can get you into some different resources to help. But I'm happy to give you some of these cards, but there are a fair amount of sober living houses on here.
I'd say housing in our community is one of the toughest things. I've got 2 nephews here at the College of Charleston. College is renovating a couple of the dorms. And so anybody that is, sophomore or higher has to find their own living arrangements. And that's very, very expensive. Very true in all of our problems treatment courts. Housing is always a challenge.
Yes, my question. Matt, good to see you again, sir.
Hey, good to see you.
Thanks. Question, is there any kind of tracking once the Narcan is given out, and I hear about a lot of Narcan being given out, which is great, but is there any kind of tracking with those folks that the Narcan is given to, if they use it, or if there's a need for it, or John Smith, you given him Narcan, do we ever check back with him in a month or so, or anything like that?
So we do as best we can. There's no formal tracking system other than that we use other than an OD map that just shows administrations. It doesn't show where we've handed out a Narcan kit. A lot of times, I say a lot of times, several times it has happened where I've been able to go back to the same place and find the same person. or the same area and find the same person. And I've spoken to them and they've used it. They've had it used on them, or they've given it to someone to run to another hotel room and used it. But we don't have any, I can't tell you that like I've distributed 100 Narcan kits and that, you know, X amount of that 100 have been utilized. But I know firsthand by speaking to a lot of the people that I speak with and interact with that the Narcan is getting used daily, fortunately and unfortunately. It is getting used. But no, to answer your question directly, there's no finite number that I could give you on like a percentage of what has been distributed is being used.
Matt, this question is for you also.
Okay.
You are in a very unique position on going into areas where we wouldn't even be aware of that we need to go, and spending time in the homeless encampments and in various areas. And what have you personally taken away from those experiences, or what has been most impactful to you personally doing that kind of work?
So it's easy to it's easy to go through these numbers and you see statistics and you speak to people who have been affected, or you hear from a news article or a story about addiction and what it looks like in the face of addiction and substance use disorder. And but in going to these places, and believe it or not, they are not hard to find. They're right here. Just look. When you stop at a stop sign, it's not hard to find. You'll find them. But when you're fortunate enough to get into a conversation with some of these people, you see the true face of addiction and the true face of mental illness and a lot of times suffering that are the things that they're just living with on a daily basis. So in getting out and making one-on-one connections, it's easier. It's easier to get more buy-in, if that's possible, to know that these aren't news articles and they're not numbers. They're actual humans. Like family members, mothers, daughters, sons that are living right here amongst us, that are living in a completely different world than we're living in. So that's been the biggest blessing and takeaway from all of it, is just getting to speak to so many people in some of the strangest places and hearing kind of where they are with their journey through the disorder and hopefully helping them in their way to a recovery.
Judge Kirby?
I just had a question, and it could be open to anybody who's on the panel. We had a meeting on Friday, and they talked about the number of overdoses that have occurred in hotels in the Charleston area and also restaurants. So how do we identify and help? I would never think the restaurants, the hotels definitely, but how are we trying to combat that issue?
As far as the hotels go, from the local law enforcement community, I know North Charleston has, and through the Act Force and the discussions we've had, I know other agencies have hit hotels and motels hard, speaking to staff, speaking to owners and managers, speaking to residents. A lot of them are long-term residents at a lot of these hotels. We've, as best we can, approach them and talk to them about treatment options, and Narcan is the biggest thing that we try and get there. Unfortunately, with a lot of that, I think the nature of the hotel motel residents is that they're transient in large part. So I can go to 4 or 5 hotels one day and then go to the 5th the next day, and no one's the same. They're constantly moving from room to room or hotel to hotel. So it's hard to really take over, like get control of one hotel, because next week it's a whole different group of people. So it's tough. But we'll continue to do what we can at the hotels and speak with them. And I think historically the food and beverage industry has seen a problem with drugs and alcohol. And there again, we're doing what we can to address management at the food and beverage establishments that we have in North Charleston, to speak with their staff and let them know that if they want, we can arrange a Narcan training to teach them, what they can do with that, as well as the college campuses too that we have there in North Charleston. We've done the same because we see the problem there as well.
And just to add on to that, we've also been doing similar Narcan trainings with the restaurant industry in the city of Charleston. And beyond just training, staff on how to use Narcan if an overdose were to occur, we also want to make sure that they're aware of recovery resources. And I found it's really great to use all the data that we get as a police department and communicating that to a lot of the nonprofits like Favor Low Country, or we're lucky to have Ben's Friends, which started in Charleston, which is a recovery group specifically for people who work in the food and beverage industry. So I was recently talking to them about creating new partnerships, and I know the Charleston Center as well does similar trainings with restaurants. So we're really trying to communicate and combine our efforts. So we're not only equipping as many people as we can with Narcan, but also making sure we're leaving resources behind for the staff, so anyone who might be struggling knows who they can call and where they can go.
I'd also add that if you look at our jail population, it actually has gone down as our population here has increased. We have better training with our police and sheriff's deputies not to arrest and take everybody to the detention center. But that also means these problem-solving courts will have fewer applicants. And so we really need to work on our civil commitment side and making sure that they are followed and making sure they're getting the treatment that they need.
Any other questions? Well, thank you to our second panel. Great job, man. Terrific, Rachel. Just let Zoe know.
Yeah, I was gonna pass them out. Yeah, that'd be great. I know that.
I was looking at you up here and I said, she's her mom. It's so good to see you. Tell your folks I said that. How the kids doing?
And our final group of panelists, please come on up. And as they're coming forward, I'm going to introduce this group. First, we have Charleston County Coroner Bobby Joe O'Neill. We also have Julie Lawrence, who is a clinical pharmacist from Roper Hospital and who's a founding member of the EDGE Drug Prevention Alliance. We also have Judge Tamara Curry, the presiding judge of the Charleston County Mental Health Court. We have Nancy Shipman, who's the founder of the recovery service organization Wake Up Carolina and Creighton's House. And we have certified peer support specialists from the Charleston Center, my friend Roberta Williams. Thank you all.
Thank you. It's good to see you.
It does make noise.
Thank you.
Hello, everybody. My name is Julie Lawrence. I'm a clinical pharmacist at Roper St. Francis. That does sound so loud. My area of focus with this problem is with prevention and education. So the first part of that is in my professional world. So in the medical, I work in a hospital. We've made drastic changes over the last 5 years. If you've been in a hospital, had interactions, with your doctor, hopefully you've seen some differences, over those last 5 years. We've learned a lot. We treat pain in a completely different way than we used to. Limiting opioids almost doing like old school, rest, ice. Two of our best friends are Tylenol and ibuprofen these days. So it's really important that you and your own families, one of the things when I speak in public that I try to encourage people to do is to be their own advocates. So when you are interacting with the medical community on your own behalf or for a family member, and there's a pain issue that's involved, you want to make sure that you have that conversation of, these are my concerns, with addiction. Give the history of anything that's in your past history with family members, other family members that have addiction. Definitely weighs in, like Dr. Bradley mentioned earlier, adds to the heightened concern. But relay what your wishes are. In our facility, we definitely have taken care of patients who wish to be have an opioid-free admission, and we do our best to try to accommodate that. Lots of methods these days, not only with drug therapy, but with non-pharmacologic, non-drugs, nerve blocks. The whole area of medicine has really advanced a lot, so that we're able to do that and give people who might be in recovery or have a large concern of being exposed to opioids, that they don't want that at all, during their admission. So that's one thing that we do. The other thing that I've been involved with over the years that's kind of related also to that is take back. Is that we remove the opioids that might be in the house from legitimate prescriptions that could fall into the hands of minors in the house or their friends or anybody who might come visit. Years ago when we started this, we were looking at the physical take-back boxes and researched, and it turned out they were $1,000 to buy a box. You wouldn't think a metal box would cost that much. But then we found that CVS had a grant program and that they would place them into law enforcement offices for free. And all you had to do was fill out some paperwork. And we had huge success. So when any law enforcement office that you happen to go into and you see a red box in there for a take-back, that came from CVS and it came from that grant program. In addition, we tell people that so the law enforcement and a lot of pharmacies have them now. So you don't need to wait until the DEA's, twice a year take-back day to empty your house and get rid of them. We do them in our hospital. We go out in the community. A lot of people still don't know that, so please spread the word. There are online locations of where you can get that. The city of Charleston was gracious enough to add a list to their website. I think it's under like recycling somewhere. That has a list of locations. And then the Just Plain Killers website that Toyota sponsors has a list of locations there. Pivoting real quick to education, that is so important to our area. Law enforcement, has relayed to us that there's only so much they can do to minimize the supply. We have to try to decrease the demand. And in order to do that, we've got to institute some prevention, evidence-based prevention techniques, and we've got to get into the schools. When we started going into the schools years ago, we were focused on high school. We thought that would be a good place to go. That's where the problem was. There definitely is a problem there. But then we really quickly learned that not only is it in the high schools, it's in the middle school, that we got to pivot earlier, much earlier than we thought, and sometimes even earlier than middle school. Is when some students are getting exposed from maybe older siblings, that sort of thing. So if I could choose anything that would make a significant impact in our community, in our area, it would be to add a drug prevention curriculum to our schools. It's badly needed. It's evidence-based. We've learned that while the presentations are good, and sometimes it'll help, one or more people that are in that audience at that one time, what really makes a difference is a curriculum that's on a regular basis over a period of time is what's been shown to reduce drug usage. So we do programs in schools. We also do programs for adults. So we have a tried and true, over these years with Wood helps us. We bring in peer students, some of the students that Wood is working with, because it's the closest in age to those high schoolers, because they can literally say, I was sitting where you were sitting,
you know, a year ago or a couple years ago, and I thought what you thought, and, you know, here's what happened to me. And that's sometimes what gets people motivated, you know, to make a change. So with that, I'll pass it on. Thank you.
Thank you. Good afternoon. My name is Tamara Curry, and I'm an associate probate judge with Charleston County. And Judge Condon has gone over drug court and explained the mental health court. But when we started mental health court, it was clear that the majority of our individuals were duly diagnosed. And one of the hardest things with drug court, and at that particular time we did not have veterans court, was really to determine which program best suited the individual, because they had drug addictions, but they also suffered with mental illnesses. So we quickly realized that a large percentage of our persons who suffered with drug addictions either eventually developed mental illnesses because of the compulsive drug use that they were having, or they had mental illnesses and so they used drugs to self-medicate. Sometimes it was generic. A lot of the persons in mental health court suffer with trauma, or it could be to deal with pain that our previous speaker just spoke about. But what statistics have shown us is that we have about 38 million people who suffer with mental illnesses. However, individuals with mental health conditions receive 51% of opioid prescriptions. So that means that the majority of the people who are using opioids have mental illness. And so how do we combat both of those issues occurring at the same time? We all know that COVID has wreaked havoc with the opioid addiction, but it also bled over to mental illness. Because what we found was that a lot of those individuals, as Dr. Funsell has indicated, they were not able to do in-person treatment. So they were doing a lot of their counseling was done virtually. Some people, especially with our mental health court participants, did not know how to log in. They could not, or they didn't have smartphones, or they didn't know how to access Zoom accounts. So that made that even more difficult. Sometimes it made it difficult for them to go in and get their medication. And so if we had a person and they had an opioid addiction, then were they able to go inpatient? And we have a number of people who have who receive medical assisted treatment. And so when you just looked at the entire quagmire of everything, it just exacerbated everything. And so what we found in our civil commitment process is the numbers just kept going up, because you had persons who were, because they could not go in for treatment, they were using more substances than they previously had. So then we would have attempted suicides. Those numbers went up. And so when you looked at the suicide rate, the commitment rate, individuals not making it to treatment, individuals not taking their medication. And as you know, if you suffer with a mental illness, after a period of time, if you don't take your mental health medication, you then will, your symptoms get worse. And as your symptoms get worse, then you have a likelihood of needing hospitalization. And the more hospitalizations that you have, sometimes it then gets harder to stabilize that person, because they keep having what we call just the cycling of, you know, not taking your meds, using illegal substances, and then possibly even using alcohol that is included with that. And so it's been a huge issue. The numbers are still up, and we know that in order, especially with the different specialty courts, our job and our focus is to look at the whole person and what is it that we can do to, number one, get them to treatment, make sure that they're taking their medication. If the issue is not being able to afford the medication, making sure that we're able to assist in that particular area. And so that's what the specialty courts do. And with our mental health court, it just means that we're looking at both issues. And with that, when we look at our dollar amounts, we have to be able to test, but we're not drug court. And so we have different grants and program and a 501c3 that we use so that we're able to send persons who are in mental health court to be tested also. Some of our people, we partner with the Charleston Center. If they are participants at the Charleston Center, then they can be tested there. And so it takes what we call a village. And so we use that village, no matter whether it's trying to send a police department for a wellness check for somebody, or me hounding Chandra, or begging to get somebody in the peer program, which is the in-person jail program that actually deals with substance abuse. So it takes everything, a little bit of everything. And but mental health courts help. And I always tell people, when I can go back and it's 8 years later, as Judge Condon has indicated, there's one of my favorite restaurants, and one person who graduated from there maybe 8 years ago, he's still working there. He's clean. He was duly diagnosed. He has been a peer support specialist at the mental health center. And so we know that these programs work. Resources are always our hardest. Bus passes to get them to treatment. We had an order yesterday for bicycles. So what we do is we buy bicycles from Walmart. We were fixing used bicycles, but we realized that it was costing so much to fix them. So we buy brand new bicycles, and those bicycles can hook on to the buses, and the buses get them to treatment. And if we can get them to treatment, make sure that they have their medication, they're able to work, assist them with getting skills through voc rehab in order to get jobs, and housing. Housing, as Judge Condon has said, our biggest hurdle. Always trying to get housing. And then it makes it a little more difficult to get housing if you suffer with a mental illness, because some of your sober living houses will not allow persons with mental illness to bring in the type of medication that they need in order to be stable. So that's another hurdle that we often have to go over. But the specialty courts work. Thank you.
Thank you. Oh, my heart is beating so fast. Hi, my name is Roberta, and I'm a person in long-term recovery. I'm also a certified peer support specialist, and I've been at the Charleston Center for almost 7 years. I started on the 4th floor, our inpatient services, as a recovery assistant. And I went to training, and now I'm a peer support specialist. And it's actually, when I lead inpatient groups, and I always let them know, for them to feel comfortable, to drop the title, I'm just a person in recovery. And that gives them like a breath of fresh air to feel that they can relate to someone who's on the path, or been on the path that they are on now. A lot of times the patient comes in and they relate to the peer support, and sometimes they say they love the group so much they don't want to leave. And it's only because that I'm able to share my experience, strength, and hope with them. And when I tell them my journey, and I let them know, and I point to them, I said, I was you, I was you, I was you, I was every one of you. And that relationship, to let them know that they're not unique, and that's one of the main points that I tried to make to them, that they are not unique, because the uniqueness is what caused them to isolate, and the shame and guilt just overcomes them, that they don't have any hope. So my job is to really just try to strengthen their hope, just give them a glare, if they can just get a glare of hope to feel that I have the willingness, I am willing, that I would try this, because she's sharing her pain, she's sharing her shortcomings, she's sharing her relationship with the disease of addiction. And I just want to add too that the stigma part of this is what really gets them down. That's what engulfs them with so much shame and guilt. So a lot of time when I approach my group, I let them know the change of language. I would actually change the language with them. And I would tell them, you're not an addict. You are a person with a substance use disorder. And I have them to repeat it. I said, you are a person with a substance use disorder. You have a disease of addiction, and we are not like normal people. But they are treatment for us, and I just continue to relate the message to them. They think I'm the best thing since sliced bread, you know, and I told them, and I tell them that, just to let them know that that was me. I was on that journey, and now I'm in recovery. But I also emphasize to them that I have not always been in recovery. And that's when I share my experience, strength, and hope with them. I share my story. My story is a story of a lot of tragedies, which they could relate to. My story is a story of dealing with, the folks was talking about drug court. I have that experience. I had a son that was in drug court. Unfortunately, he didn't graduate, he didn't make it. But I had that experience, and when you can share that experience with them, it's just a part of them that feels that, oh, I feel like I belong. They just want to be able to belong to someone who feels their pain, can share their pain, and give them a sense of hope that this could happen, And I tell them, and I emphasize that it's a one day at a time, I also let them know that there are days that you can come and not feel good, it's okay. That's a big sentence for people that struggle with the use of with drugs and active addiction, that it's okay to feel bad today. It's okay that you don't feel like sharing today. See, I give them that room to let them know that it's okay. I respect how you feel. And a lot of times not most of the times when I walk into my group, I write 3 words on the board: feelings, thoughts, and behaviors. And I let them know how important feelings are, because feelings gives you the thought, and the thought is your reaction to behaviors. So when I have a list of case clients as well as inpatient groups, I kind of advocate for my clients with housing, employment. I just had a client that was able to get food, something as simple as food, because he didn't have anything to eat. So I kind of team up with the clinician, which I deal with some really great clinicians, and she was able to get a food bank to have him on the rotation. And when he came back, he was in tears because he's getting food. And I also have, I like to thank Caitlin. Caitlin sends all these resources. And I think one of the biggest resources she said was the felon friendlies, the different agencies that hire people with felons. And it's a long list. And I was very impressed. So to pass that on to them, it goes back to the hope, and that's all they want is hope. So those of you that have family members, I know of someone that's still struggling with the disease, the substance use disorder, all they want sometimes is just understanding. just to know what's really going on, but because they don't know how to express it. When you are bombarded with the stigma, you know, and they even share some of the names they are called, you know, and I just try to educate them and let them feel like they're human, you know, they're not aliens, you know, they are someone, and then there's always a chance to make better choices if you just stay on the path. And one of the things that I emphasize them is my path was the 12-step program that works for me. But I also emphasize to them that it's the path that works for you. I'm not sure if the 12-step would work for them, but I do share my experience, strength, and hope of being on the suggested 12 steps of recovery. I attend meetings. I suggest meetings to them. I pick up my clients. I take them to resources when they don't have the transportation. But it's a mission. It's not a job for me. It's something that I love. It's a lot of things that happened to me while I was in recovery that I feel proud to be a part of today. So what I would do, I just continue to carry a message of hope to my clients. And thank you guys in Wood for having me here, and an awesome panel.
I'm not the best with microphones. I'm Nancy Shipman, the executive director at Wake Up Carolina. We are a recovery community organization as well as a nonprofit. And many people don't know what a recovery community organization is, or an RCO. We are one of two in Charleston. It's Favor Low Country and then us. I had no idea what recovery was until my life was touched. And so I'm passionate about recovery. I'm passionate about life. And 5.5 years ago, I lost my 19-year-old son, the oldest of 5 kids. And this community, and it's crazy, this community stood through the darkest day and held us up. They supported our family in Creighton and recognized that it was a disease. And stories were shared. And from that moment, I realized no one should have to lose someone they love to feel supported. So there was no great idea to start a recovery community organization. I had no idea what that was, much less a nonprofit. So what that grew into is learning from our community. What's being done? What isn't being done? Where are the gaps? What are the barriers? What are the low-hanging fruit? And where are we? What do we do? You know, immediately where you go is you want to make big changes and, you know, you're passionate and that's not sustainable. I learned that real quick. My passion isn't sustainable. What is sustainable is truly digging deep in your community, the community that held you up, the community that's willing to share their own stories of recovery, not that they're experts in anything but their lived experience, and willing to share their story with you and hope to make something different, make something better for the next person to come along. So I say, you know, I lost my son 5.5 years ago. We started providing services 3.5 years ago. The very first service we provided without a space was our young adult program, and that's called Creighton's House. The heart of that is that it serves 14 to 25-year-olds, kids that would be going into high school through college. We weren't trying to repeat what's being done already in recovery groups because we need them. What we were trying to do is hold open a door for if Creighton would have come home to find his people, to be able to walk through that door with those in sustained recovery, to show how to have a supported life free of substances with people that looked like him, sounded like him, and had shared experience. So what started out with one recovery program director for Creighton's House, where I knew I couldn't do it. I mean, I'm not in recovery, I'm a family member in recovery, but she grew this little egg from an idea into a program. And then one of the attendees that came to those meetings, when it was time for her to go finish her master's, he was the new program director. And so he served
for 2 years as the program director of the young adult group and built a culture. And then it's his turn to finish his last semester and last year in master's. And another young person that has come through the young adult group is now our program director. And she is just doing amazing things. Last week, we had our highest number for that group. We had 22 young adults coming to our meeting on a Thursday night. And the even cooler thing about it is they'll stay an hour over pizza, over a meeting, and then they spend about 45 minutes outside just catching up and talking and fast friends. So that's the heart. And then where we went from there is we were thankful enough to partner with Charleston Center and the Mount Pleasant Police Department to do community Narcan distribution. We believed in if there's breath, there's hope. And with hope, we can hold that door open with the many community partners there are in this great community. So from there, we grew into a mother's gathering, which we are at capacity at that. We have anywhere from 15 to 24 mothers, whether they birthed them, fostered them, or adopted them. We're bound by mothers' hearts. And so we have this mothers group that meets every Tuesday. We have a dad to dad. And it's funny when you learn along the way. I had a mom say, my husband really wants to come to this mom's meeting. And I was like, no, we're not having a dad come to the mom's meeting. It's mom's for a reason, our mother's heart. He doesn't have one. And I said, we can wait. Well, it's funny, the very next day, and if you don't know what your plan is, someone always lights it up. Very next day, a dad walked into my office, and it was about a professional thing. And then he said, do you have a minute? And a lot of you know that serve in this field, when someone says, do you have a minute after they give you your little spiel, it's something personal. I said, of course. And then he shared about his adult son. And with that, he said, I need more dads. I need dads to be able to sit with me, maybe coffee and donuts, something to get us at a table. And I was like, well, that's funny you say that. So that's what birthed our dad to dad. I said no, and then the very next day a dad comes in and says yes. And I was like, okay. And so I have 2 dads that have Family Impact that run that Wednesday nights at 7 o'clock. Creighton's house is Thursday. We have an all-recovery meeting Friday. It's very small. It's new. It's our newest program. And then one weekend, one night a month, we have a Creighton's night out. And the kids, they're all young people. They decide what they're doing. It's this Saturday, and they're having a night in instead of doing something that they said out. They want to be in space. So they're having tacos and cookies and watching Netflix. And, we do other things too. Harm reduction. We do a stepping stones program with women leaving the state prison to help gain access to sober living. We do treatment scholarships. We started with 3 programs, and when COVID hit, we turned into 11. We signed our lease. We were so excited. I know we're not the only ones hit by this, but February 2020, we finally got our space. People didn't have to donate a room once a week, changing nights. I signed the lease, and of course, what happens in March 2020? COVID. So it's funny how things happen, but you get creative. So with all that being said, it's a privilege to be able to serve with everyone that's in this room. I mean, literally everyone in this room I've either had a phone call with, a meeting with, and we've creatively built something so much bigger than us. It is this, I truly believe in a tapestry. I bring that up so often, but this tapestry of our greater Charleston community is really about one life. If we can help one person, one family with this family disease, then we're making it a little bit better. And, maybe I can't get Creighton back from heaven to heal him and help him get in recovery, but for me, I will continually be working on my own recovery as a family member. And this is a family disease, a family recovery, and it's a community recovery. And I'm just really thankful, Gil and Wood, that y'all put this together, because when we talk about stigma breaking, to me, this is a huge stigma breaker right here, having all these people, all these professionals, personal impact in one room for one purpose. So thanks.
Well, I'm Bobby Jo O'Neill. I'm the Charleston County Coroner. And so one might ask, why is the coroner sitting up here with these ladies? And it's because we want to be a part of the solution. I've been in the coroner's office for over 20 years. And one of our responsibilities as being coroner is that after a death has occurred, we are the one that knocks on that door and notifies that family that that death has occurred. In my 20 years, I have knocked on many, many doors. And behind that door, especially with cases where we suspected a drug overdose, what I heard from families is that they had anticipated our knock, that they were waiting for the day that we were coming to their house. They had lost hope. They had lost exactly what was mentioned here. They had struggled through the systems. They had struggled with their loved one. They had struggled in their family, and all of their hope was lost. And so what can the coroner bring? I want to sort of start with some numbers because I'm hoping some of them are hopeful. Here in Charleston County, back in 2019, we lost 150 of our community members to an unintentional drug overdose. That skyrocketed in 2020 to 180. In 2021, our number is actually pretty steady. We're about 175 with a couple of cases pending because we are waiting toxicology testing. And right now for 2020, we have 30 that are pending. So what does pending mean? Well, it means that we're waiting on toxicology results, which can take 6 to 8 weeks for us to get back. So what can the coroner do? Well, one, we're trying to work on a system in the coroner's office where instead of sending off a lab test to a forensic lab that takes 6 to 8 weeks, that we're getting immediate toxicology testing in the autopsy room so we can provide information immediately on real-time data that's going to our law enforcement community, our mental health community, and our public health community on what we're literally seeing as regards to fatalities. The other thing that we have been greatly involved in is being a part of the Opioid Fatality Review Committee and bringing to that table a review of the death that we've investigated and what are the gaps in our community and how can we fix those. Are those gaps service related? Are those gaps law enforcement related? One of the questions came up is there Narcan? And we've gotten to where we are now asking all families, did you have Narcan available? Are you familiar with Narcan? How can we gather that information so that our stakeholders here that we've heard all day can take that back to the respective organizations and figure out how to improve our systems so that those families that are struggling with this don't meet me. That's the goal, not to meet the coroner. And the third thing that we're doing is bringing support services and referral. The coroner and my investigators, we work with families one-on-one. Again, we're the one knocking on the door. We're the ones that are sitting there with their family members. We may be sitting there with their roommate. And so to be able to recognize at that moment that I have a grieving mom, that I can refer to Nancy, that I have a grieving roommate, that we can refer to services to Dr. Funsell, that we have something going on inside that home, and how do we, right then and there, at the time that the death has occurred, although they are grieving, we also need to get them into support and services. That's why the coroner's involved. We want to be a part of this solution. I think that we're responsive, but there's a lot of information and education we can provide back to our community. And although once it's come to the coroner, there's nothing we can do for that individual, but the information that we can use and provide is going to impact the living, and that's what we're all here for, is to bring some hope back to the communities that are suffering. And so I'm just really glad to be a part of that. Thank you.
Well, sure, I'll start. We've heard 3 panels now and Dr. Gupta, and we've heard all about treatment and recovery, and we've heard it from every discipline, the judiciary, prosecutors, law enforcement, and of course, all of the different treatment specialists, et cetera. And we've all talked about the humanitarianism, or listened about the humanitarianism, the importance of saving lives, et cetera. But no one really mentioned money, the cost savings. They've talked about, look, we could use more resources, et cetera. And I think if I was sitting in the audience and I wanted to be a devil's advocate, I said, well, how much is all this costing us, et cetera? And I think that one of the important points that sometimes gets overlooked by all of the people that have been doing all of this work is how much more cost-effective treatment is than incarceration. And that's why you have all of these different groups kind of coming together saying, you know what, it is a lot less expensive to get people in treatment than it is to warehouse them in a facility. And when they come back, if they're able to go into recovery, and especially long-term recovery, and they're back being a taxpayer, they're back being taking care of their family, they're back in the workforce, et cetera. And when I had Dr. Gupta's job, the governor of West Virginia said, look, he said, we're spending a lot of money for treatment. And he said, what happens is that we get people then to go and take some of the jobs. And the first thing that the job applicant has to do is take a drug test. Well, if they know the drug test is tomorrow, they don't show up. Or if they show up, they fail. And he said, so what we're going to do is invest money early to make sure that people don't fail that drug test and to make sure that they can be a part of the community. And so, you know, sometimes we never really look at those hard dollar costs because we're all doing the right thing by people, but it saves a lot of money. It's more of a statement than a question, but I'd be happy for any of you to mention that.
Well, definitely with mental health court, statistics show that the majority or a large percentage of people who were housed in jail suffer with mental illness, and it's really one of the largest costs, the medication that it actually takes when people are incarcerated. And then when you look at the recidivism, if you can keep them out of jail and what it costs to house someone for a year, it is so much cheaper when you're looking at treatment and getting to the root cause of why the person is incarcerated, whether or not it's substance abuse or mental illness. And truthfully, that's one of the first thing that we actually tell individuals, especially when you're looking at funding sources, how much money it's going to save, whether or not it's a county or a federal prison or a jail, definitely.
Questions? Anyone else? Sure.
It's for the
Oh, okay. Thank you very much. Hello. I guess this question is for Nancy. On the issue of stigma, do you think it's any different for the 14-year-old or the 15-year-old than it is for the 35-year-old? Or is it the same?
I think stigma is stigma, but from my understanding, what stigma is felt by our younger adults, like our 8th and 9th and 10th graders, and this is from my understanding, just from listening, because I'm no longer that age. All we can do is listen. It's different than what I see with our adults that we serve. Whether it is heard, whether it's felt, whether it's read, it's that voice in their head as well. And wherever it's reinforced, whether it's a conversation inadvertently with a parent saying, "I hope you would never do this," and this kid is in there 16 or 17 years old and he already has, he is compounding his stigma like, I'm a bad person, I'm a bad son, I'm a bad this, I'm a bad that. And my hope is that in schools, in youth groups, however that get, is that your actions aren't who you are. And if we can start identifying the actions of someone misusing, or substance use disorder, these are the behaviors or the actions, but they're not the person. I think the stigma for the young adult or the 30-year-old or the 28-year-old would really stop. But I do know their stigma is felt, shame is immediately felt, they don't want to share. But I think it looks different from my small experience with individuals compared to like our 8th and 9th and 10th graders. Is that answering it?
I think it's interesting that working with surviving families, that they have a stigma too. You know, that many times when we have to provide that information that their loved one did die from an unintentional drug overdose, that they don't want us to tell anybody. They sometimes don't want that on the death certificate. That is another stigma, that even though they may not be the person who has the addiction or substance abuse disorder or whatever they are calling it, that they feel a stigma as a survivor. And so we also have to impact them as well.
I'm so glad you brought that up, because that's one of the biggest pieces of what we do is family stigma is almost louder. From my own personal experience and from the phone calls and all the people we serve is, what did I do wrong? What did I not do? I could have done this, and it's all the could have, would have, ifs. And if it was that easy, then we wouldn't have addiction if it was all caused by a parent. But our stigma is we start isolating. We start having very similar characteristics as someone that's struggling. That's something that I look back on my own life, and I mimicked my son's behavior, and now I see that so very often.
And I think even at that death notification, we're starting to break that down by telling them they're not alone, and referring them to someone like Nancy who can understand exactly where they are.
Let's thank our panel.
Thank you all so much. It's been an honor to have everyone at the college today. I thank you to all of you who work, and the people left here today, work in this field, and we work together. And we thank Gil and Judge Hendricks for creating the ACT force that's been so inclusive, and we've all learned so much. So thank you. We hope you learned today about the many organizations who are working locally, statewide, and federally to help those who are affected by substance use disorder. But we also hope you learn that recovery is possible. Thanks very much.